Building a family can be a complicated, messy, lonely, and sometimes heartbreaking process. But you don't have to navigate this challenging journey alone.
Welcome to the AllPaths podcast, where we support and celebrate all of the different ways there are to try to grow your family. We are your hosts, Kate and Emily from the nonprofit organization AllPaths Family Building. And today we're talking with our friend and colleague, Dr. Aaron Styer, about his work as a reproductive endocrinologist and how patients can set themselves up for success. Aaron, thank you so much for joining us today.
Thanks so much, Kate and Emily. Great to be here, and thank you for inviting me. Very excited to chat with you guys today.
Thank you. Well, we know you very well because among your many hats that you wear, you're also a board member of AllPaths Family Building, which we're so grateful for. So we know you, but for our listeners, will you please briefly introduce yourself?
Yes, so my name is Aaron Styer. I am a endocrinologist and fertility specialist. I'm the medical director here at CCRM Boston Fertility. And I have been practicing the area for the past, I'd say, 20 years or so. Originally, I trained at Brigham Women's and Mass General for my residency and fellowship. And I practiced in Mass General for about 15 years until I co-founded CCRM Boston here in Chestnut Hill. I've had the distinct privilege of being a board member of previously resided in New England, now AllPaths. And I've gotten to know you and Emily and all the board members quite well and been so energized by all the work we've done to really support our population of folks here who are looking to build their family, who are looking to adopt, who are looking to do whatever it is they prefer or look for in family building. So really exciting to be here and really just chat about really helping patients succeed in the process. Sometimes a daunting process, sometimes an exhilarating process, but nonetheless, there are certain things that I've found over the past couple decades that really do achieve a few goals. Number one, helping folks get through in an easier way, reducing the anxiety associated with infertility and fertility services. And I think the final thing is empowering patients to really know that they can control the process and success is always in their reach. And so, that's really looking forward to talking about that today with you guys.
Thank you so much. Well, you're speaking our language about support and empowerment are two of our favorite words. So before we get into that, which we're so excited to talk about, can we look back a little bit and will you share with us how did your professional path lead you to fertility as your specialty and just medicine in general? Did you always want to be a doctor?
So it's interesting you say that. I had, for whatever reason, always was fascinated by a stethoscope and a white coat. And I can tell you, it goes back to the fact that I come from a family of nurses. So my grandmother was a nurse. My mother is a nurse. My wife's a nurse. And so I remember even my grandmother going to the old, I grew up in Pennsylvania. She worked at the old Philadelphia General Hospital, or PGH, which was, they called it back then, in her nursing uniform and her stethoscope. And I remember so just enthralled by the fact that you could go and take care of patients in this hospital. And so really it branched out to maternity visits, believe it or not. And so I'm the oldest of four. I have three younger sisters. And so I used to go with my mom when I was like, 5, 6, 7 to her prenatal appointments after school because she would take me after work. And when I was in the offices, I would see these posters of babies and birth, kind of movements of birth and labor in general. And I was so amazed by that our bodies could achieve, number one, conceiving, and then also nurturing this human being for 10 months and or 9 to 10 months, and then finally delivering. And then ultimately this happened 3 times for me because I have three siblings. And so that was the first fascination of reproduction and just the old part of pregnancy. And then when I was in medical school, I was dead set on, I went to Vanderbilt for medical school. They had an incredible labor and delivery unit. Many of my prior mentors back 20 years ago really inspired me to go into OBGYN because it really was the realization of my prior childhood fascination when I got to deliver babies, take care of women in labor, and also perform reproductive surgeries. And so with that, I applied to residencies and I matched at Brigham Women's and Mass General. and had an incredible experience here in Boston with this very high level hospitals and high level faculty. And during that time, I got to, really take care of several patients in my own clinic who were struggling with fertility. And during that time, I realized that although I really did enjoy delivering babies and being an obstetrician, the part that I really was fascinated was the preconception, the early stages of pregnancy. And so working with these patients and these couples, I really came to love the personal relationship you had with those folks who came to see you who were either vulnerable, they were unsure, who they sometimes successful, sometimes successful. And so you really got to manage and to help and to get them to a better place than they were when they first saw you. So I was really drawn by that relationship and that privilege to really help folks go and help them build their families and help them plan their families. And so with that, then I applied to fellowships and I matched at Mass General Hospital and did my fellowship there for 3 years. And during that time, still the embodiment of what I really got in the field was going to be relationships with folks, building families, and also the really cool part about my job is I get to be part of someone's special story. And I have many patients in CCRM and MGH who have multiple children through multiple different treatment cycles. And so I get to, see them sometimes in person or yearly. I always ask for holiday cards. And so I get the cards and I see, how their children have grown up over the years. I'm getting a little bit older now. Some of their kids are teenagers now. And so going from being a medical student to someone who in residency and fellowship, it really went from the relationship, which is still is there, but also being part of the family building story for many different families. And when I see many patients still in the street or at a mall or wherever else it is, and you stop for a second. I still remember all of them because nobody can ever forget when somebody came to you when they need some help or they were in a place where it was a dark day or a dark moment. And so for me, that's what really has drove me to getting into the relationship, but also what helps me get up every day and be excited about what I'm going to be doing that day or that week is really that special bond and special link with individuals, with couples to help them really build their story, not just for now, but their story for the this generation, for the next generation. That was really what really drew me was the initial, fascination with the hospital, and then prenatal visits with my mom, and then finally getting into just the relationships, and now being part of the story for those who really need help and really want to build their family in the future.
Well, that's so neat that it's been kind of a lifelong journey to get to this point where now, you are, like you said, part of so many other family stories.
It is. It definitely is a different levels of excitement, of enthusiasm, of still fascination, and just having a lot of fun. That thing I always say, if you can't wake up in the morning, you can't have fun, you should change what you're doing. And for me, although yes, some days can be busy, some days can be stressful, every time I wake up, I think about, who else I'm going to meet or see again, and what more we can do to help them realize their dream. And I think that's such a incredible honor to have, especially in this situation where there's a certain number of things in life that are I consider to be intimate or special. Conceiving, knowing you're pregnant, having your first, second, or third child. Sometimes other things can be related to other medical things that come up in life, but I find this is one of the more special times of anyone's life that myself and many people in my specialty really have the privilege of being in. So it definitely has changed rather, and it continues to evolve because as I see new patients come through who are younger, it's not just family building, it's also fertility preservation. It's also patients who are undergoing gender transition. It is patients who are, may have a unexpected diagnosis of cancer who need my help to help them freeze their eggs or their embryos if they have a partner. Or what I've seen, there's an expansion of fertility benefits now, where folks will say, well, I just want to understand best where am I right now? I don't want to build my family now, but I'm a planner and I have benefits and I just want to do some testing. I want to understand where I am. And so, as you point out, Emily, it's this mixed and beautifully mixed and diverse portfolio and bag of people that we get to see that definitely has expanded over the past 20 years from just straight infertility to fertility preservation to gender transition to other things as well. So, it's been really exciting.
So, what does a typical day look like for you?
Yeah, so it depends upon, whether I'm doing procedures or I'm not doing procedures. So basically, as looking at the way our practice is set up, you know, a physician is assigned to do egg retrievals just for IVF or embryo transfers. And then if you're not doing those, then you're either seeing patients by telemedicine or in person to talk about, their next steps for treatment, or you're meeting new patients, or you're doing pregnancy ultrasounds or office procedures. So for me, if I'm not doing procedures, I'm seeing patients either in person or by telemedicine, doing either new patient visits where I'm getting to meet someone, whether it be the first time or maybe somebody's coming in for a second opinion, or I'm seeing somebody who's had their testing and I've seen them before, I'm seeing them again to review their test results and talk about their treatment options. That's the first thing. I get here about 7 o'clock. I usually start about 8 o'clock. And so between 7 to 8, I prepare my day, I prepare my notes. If there's some of my patients who either have a challenging ultrasound, who are undergoing monitoring, or I haven't met before, because sometimes that does happen with telemedicine, I'll pop in and do their scan so I can meet them. Or if there's something that's difficult, say somebody has not the most best response, I find it's easier if I see them in person and scan them. We can talk in the room in real time instead of me calling them a later day and they may be busy to do that. And then at 8 o'clock, once that 7 to 8 is over and my prep or my scans are done, then I will start seeing patients telemedicine or in person. And then usually we'll have meetings middle of the day. And then the second half day or the afternoon, I would do the same thing again, do patient visits. And then on the days where I'm procedure, we start at 7 o'clock. We do egg retrievals, and then we do embryo transfers or other kind of procedures in the operating room. And then after the morning's over, then I'll go and do my visits with patients as well. So it's a really exciting diversity of things that we get to do here, whether it be procedures, patient visits, office procedures, or even my most fun part is going to be pregnancy scans. People who have gotten pregnant with treatments, you get to see them before they graduate to see their OB/GYN. So you get to kind of relive and recount kind of what you've gone through with them. And I can tell you many of them don't want to leave. They're like, can I stay here until
I
till I'm
know.
term, because they've been there for a
Yes.
long time. And so
Hmm.
they've been supported the entire time. And now they are like, I don't want to leave. I don't want to go to a new place, but we have so
Hmm.
many incredible OB/GYNs in the area that, we always reassure them that it's going to be good. It's going to be fine when they leave.
Still such a hard
It's a
transition.
good thing, but it's a hard
I
transition.
know,
Yeah.
I know,
It's a
I know.
relationship that's been formed.
It is.
So, well, it is so cool to hear sort of like the other side, because obviously, like Emily and I have the perspective of having been patients, but not necessarily like what your days look like. But so, from the patient side, I think that first visit, whether it's telemedicine or in person, that first visit with the RE is so, and like built up in your mind and heart. And so, what is your advice for folks about preparing for that first visit with an RE?
Yeah, so I can tell you just a personal experience of, my prior experience with being a patient myself. And I remember even as someone who does this every time, walking into that visit and feeling quite vulnerable, feeling quite unsure, feeling just fearful of what may come out of the visit. And I can say to you, I left the business saying, I've been doing this for over a decade. This is a while ago. And I said, if I feel this way, how do other patients feel? So I think there's a lot of things that you have to think about. I think, think about a couple things, kind of general questions, initially, such as, okay, is this the primary site of where I'm going to be having my testing? Um, you know, how do you assign nursing care? Who will help me organize my visits? What is your structure for after hours calling? Um, when I communicate with, my team, do I do it through portal? Does it a phone call? Those are all pretty straightforward things I think that are important. I kind of think is kind of housekeeping things to really go through. And then, I think when they get to the visit, you kind of want to do a couple of things. Ask them about the testing that you'll be doing. The doctor will review it with you, but you want to ask why. So why would you be getting this testing from me? What is the timing of the testing? Is it happening at a certain time of my cycle? Is it not related to my cycle? If I have a partner, does my partner have to get testing? If so, when does it have to happen? And then the other thing is going to be, besides that is you know, making sure that you have a financial contact as well as make sure your testing's covered, make sure that there is, potential benefits for treatment. Other things that are important too is asking about the size of the practice. How many doctors are there? Also when people don't ask this, but people should really see and ask, why is your practice different than other practices in the area? Because many times people get referred by their OB/GYN, their primary care doctor, or their friend. But you can ask and say, well, tell me, how would you characterize at the end, how would you characterize your practice? Is it more of a efficiency driven, volume driven practice? Is it a high touch, practice where there's high touches between my nurse and me or you and myself as a physician? And then after you kind of get a sense of the flavor of the personality of the practice and the logistics, you also want to, get a sense of kind of, based upon what you learn today, what's your sense of kind of what our direction may be? And then finally, the last thing I think during the visit, which usually is between 30 to 45 minutes, is going to be, what can I do for myself as a patient or a couple to optimize our chances for whatever we're looking for. So definitely ask about things related to dietary modifications, habits, exercise, and other holistic options such as acupuncture, Reiki therapy. I think that besides the nuts and bolts of what testing I'm going to get, why I'm going to get testing, treatment options, outside the medical realm, what can we be doing when we're not here in your facility that we can do to help ourselves? I think that's a really good way to start with a visit because I think the physician, I know myself, I really want to get a sense of confirming their history, confirming why they're here to see us, looking at any prior testing that they've done, confirming testing they've done, and then thinking about, okay, we're going to get this other testing for this reason. And then outlining for patients what I do, what are the reliable or sorry, predictable next steps for them. And I think if you give patients a predictable next step and a something to look forward to, it reduces anxiety, gives them a path, gives them a blueprint. But I think also too, you want the patient to know that, hey, I want you to be thinking about these things, supplements, exercise. Because at the end of the day, I look at this as a partnership in care. This is not me as your doctor, you as a patient, me telling you what to do, you do what I tell you to do. That is not how I practice. It really comes down to we're working together for a common goal, whether it be understanding just what your fertility potential is, whether it be fertility preservation, whether it be having a child or children, and what things can I do to get myself there in the most efficient way and the most effective way possible. And the last part, as I pointed out in the initial intro, is by doing these things, it also empowers patients to know they do have a contribution and control over the events to come, whether it be, how they do in their cycle, whether it be them being more educated about what they're doing. But I think overall, they're active participant in everything. I think that's especially important, say, some people have their partner, don't have the partner in the first visit. But I think if the partners there, definitely I try to really emphasize that this is a group contribution, a group
Yeah.
effort. And I
Mhm.
think you'll see a lot of the patients' partners from being sitting back in their chair, they start to ease up in their chair like this and they become more engaged. And you
I
notice the
love
patient
that.
really does appreciate that because you've now
Mhm.
engaged their partner to say, this is not just an uterus
I'm a
and ovary
spectator.
thing, it's
Mhm.
everybody's contribution here. So that would be my advice with the first visit is really think about those medical things, non-medical things, bring them together and really emphasize contributions and the participation for everybody who's involved.
That's great.
That's fantastic. I know that annoyed the hell out of my husband. I mean, we had both male and female factors.
Yeah.
So it was everybody, but I think they actually spoke to him like twice in all of the years that we were
Yeah.
there. So it's
Yeah.
really lovely to hear how you pull everybody in.
Well, did you say
Yeah.
that because it's like, it's with the times too, Emily. I think that luckily, we've learned, all of us have learned to be so much more inclusive than we were 10, 15 years ago, no matter what it is in life. And I find that in medicine too, it's not, and again, I always want to emphasize this to anybody, a third of the time it could be on the ovary uterus side, a third time it could be on the sperm side, and then third time it can be both sides together.
That
And
was us.
so because of that, you don't know, you can't just say there's one side. And one thing to bring up too is say there's a really severe male factor, for instance, but the female side is, or the ovaries uterus side is appropriate. You still want to emphasize as a group effort because I don't want anybody to feel like it's their fault, right? Or for instance, say somebody comes in who's 42 years of age and this person has a very low egg reserve and the sperm is looking great. Okay. Like really, really good. Sperm's awesome. I'm not going to say that during the visit, right? I'm going to say the sperm looks appropriate because you don't want, there's sometimes some dynamics there where you want to make sure that you balance things so that one person doesn't walk away thinking our lack of success is due to me.
Hmm.
It's a share. It's almost like the same thing you look at a team. A team wins together if they all put the work in. And on the same side, a team either doesn't win, but it's a group effort. It's not just one person, one individual. So I look at it as a team, and as you point out, Emily, back when you probably did this, it probably wasn't like that. It was kind of like, we're going to focus on the ovaries and uterus, and the sperm's just the sperm. It's not really that important. But in reality, everybody's important when it comes to this whole process.
We also didn't have you as our RE, so.
I know. Ugh, I wish. So Aaron,
Yeah.
are those so everything you just outlined in terms of kind of the things, the questions to have going into your first visit with an RE,
Mm.
are those for everybody or are those specifically for people who this is their first time visiting an RE? Like if you're coming to you for a second opinion
Yeah. Yeah.
after being with another clinic or another doctor, are there other questions that you want to be asking, or is that still kind of the same outline?
It's the same outline, but as you know, Emily, patients who have done second opinions, which I think is great to do because this is high stakes, high emotion, just really important life event here. Many people who have second opinions have already done this before, and so many patients are quite experienced. And so many second opinions, they kind of know what to ask. And so I'd say it does apply to them, and they can probably get through a lot more quick because they've already done this before. But with the second opinions, there's a different framework that I really suggest they think about too. And the first one is making sure that we have their records in advance. And the records really involve their prior diagnostic testing, their prior treatment records, and trying to make sure these things are in place at least hopefully a week before I see them. One thing I also recommend is sometimes it's hard to get records nowadays. It's just medical records facilities are difficult. They just takes longer to send them to us. And so sometimes folks can just request their own records, have a copy of their own records and bring them with them or send them to us. That's maybe the more efficient way to do it because they'll release them to an individual faster than they will to another facility. So that's one thing to think about. And also a lot of my patients actually will summarize their courses just in basic ways, such as they did IVF cycle. Okay, IVF number one, they had 8 eggs, so many eggs fertilized, so many embryos were created, how many embryos were transferred, how many embryos were tested, how many embryos were normal that were tested. Some patients just actually have a summary of their own from their treatments, which I do definitely recommend because many of us who've done this for a while, I can really work and figure it out with not a lot of information, because I can kind of I know how folks practice here in the city. I know different styles in different areas here in the city. So I know kind of what they probably had done so other places. And so really definitely having hard records, but also their summary is really important. Um, and then the final thing is going to be, I know patients want to be as preemptive as possible. Sometimes folks will come to see me when they're already still somewhere else in treatment. And sometimes it's not the best use of their time because I need that outcome from their treatment cycle that's happening currently to really form an opinion. So I think that's one thing I always say is, well, I'm always happy to see anybody. I've never turned anybody away, obviously, but sometimes it's more difficult because we have to wait for it to happen. They have to see me again afterwards, So I think ultimately, but sometimes the visit comes up where I'm available, more quickly than they thought, so they'll come see me. But I think the one thing about the second meeting is really going to be summarizing what happened before, testing outcomes. Also, one important thing is I always ask patients, so tell me, after your last visit, what did your doctor share with you about their impression about your prognosis, about your chances, or about what they would do in the future? Because for me, that's helpful because that person who they saw before knows them better than I do at that point in time. So what I can do is take their records, take their summary, and then get their impression from their doctor they saw before. And in my mind, I can formulate, what could possibly be done for them in the future, for treatment. So that's one other thing I think that's really important is also the impression of their prior physician when they come in. So to answer your first point, Emily, our question, Emily, is really going to be the basic structure we talked about for first visit, but also these extra things that include records, summarizing prior treatments, and also prior impressions from before where they were before they saw me.
That's great. Well, I like how really a lot of what you've talked about is about optimizing. I mean, I think, so like optimizing that second opinion visit would be to really be at a crossroads
Yeah.
where ideally where you've paused at least from your prior care and are
Mhm.
looking for more information and potentially
Mhm.
going to make a change.
Mhm.
Because as we know all too well, like there's so much of this we can't control, but
Yeah.
it does not mean you can't control anything. You
Right.
can do these different things that we've talked about, whether they're behavioral or just strategies for optimizing. I do like that word because we know there's no guarantees with this, unfortunately, but it does feel empowering. Another word you used before, it does feel empowering to have some control over some
Mhm.
aspects of this. So I think
Yes.
that's really great advice. So, how do you navigate the conversations with patients when they are at a crossroads clinically? For example, say they kind of were planning to do or have been doing IVF with their own gametes and then are going to potentially, your advice might be for them to shift gears to donor conception. How do
Yes.
you kind of navigate those changes and those conversations?
Yeah, those are probably the most challenging. And so, I always say to everyone that is at that crossroads, nobody ever wakes up in the morning and says, I'm going to do donor egg. That's something that doesn't happen. Okay. If you're going to have that transition, it's going to take a while to really process it and really embrace it at some point if you're going to do it. So what I always say when I'm seeing somebody at crossroads, I'm going to say, listen, I put myself in your place, but I'm the patient, but I have the expertise of your physician. And I'm looking at this as somebody who has a lot of prior experience of seeing different trends, seeing different results, seeing different outcomes, and thinking about, I say to them, I'm going to be upfront and honest with you. Sometimes that is not going to be that what I'm going to say is not what you want to hear. But I say to them, there's two different things, whether I can or I cannot help you with what I have here where I am a physician. And so when we sit down, we go through everything, and I say to them, okay, after this point in time, these are the interventions I would suggest to hopefully have a better outcome. And if that's the case, then we say we can move on with another additional treatment cycle. However, I also think about what the limitations could be, and I actually give them a sense of kind of what could happen potentially downstream if we did this new protocol, including they could have recurrence of lower egg yield. They could have a recurrence of not many embryos that make it to a certain stage. They could have recurrence of having still abnormal embryos. They could have lack of implantation, lack of successful transfer. So I would go over those things, but if I feel based on what I'm seeing here that we can add another layer or two of intervention that would help them do better than they did before, then I will up front, that's what I would say. However, other people I'd say, say that somebody has very limited egg reserve or somebody has done many, many cycles with the same outcome, and there's certain things that I know I can't change. We'll go through everything and I will at the end, really say to them, you know, based upon what I'm seeing here, there's nothing more that I think we could do here that'd be different than where you were before. I think the outcome would be probably the same, unfortunately. In some cases, I'd say if you felt as though you needed to do another cycle, although you hear what I'm saying as a closure, and it's appropriate, from a financial and insurance thing wise for them, then we offer that, because I think that sometimes not everything goes according to data or to science. And we know that some people have either gotten pregnant when they told they couldn't get pregnant, or they do a last cycle and they conceive. So there is that area of patients who are not correct ready for that transition, but they understand there's not much more of a better outcome that we would expect. And then the other side of things is those who, we know that we can't really intervene with what we have here. We probably consider donor egg. But donor egg, I think about it this way. I think it's just a change that we're going to be thinking about making here. You have to be comfortable with the prospect that we'd be using someone else's eggs. This is for donor egg, for instance, or it could be donor sperm too, if it was the sperm donor, to help you build your family. And everybody has different comfort levels. And I would say this is a personal choice. Just because we have the technology doesn't mean you have to use it. And when you say that, the patients or the couples that I see, they don't feel like I'm here to see the Dr. Styer. He has his technology and laboratory. I'm here to talk about donor egg. I don't feel like I'm obliged to do anything. I'm just here to talk and to listen and to think about my options. And I said, if those options, such as donor egg or donor sperm, are not something you're comfortable with, there's also adoption that is also another option you can consider. So, although they may come in thinking there may not be a lot of choices, there are choices. They have to think about which choices they're comfortable with. But I emphasize the point that this is not an easy decision. I don't in any way, shape, or form expect to make a decision today or tomorrow or the next week about doing donor egg. It may take them some time. And also, if they want to circle back with me after they thought about it, they can. One other thing I bring up too, especially if it's a couple, whether it be two women, two men, whatever it designations are, is, sometimes partners disagree as well. And so everybody has to be aligned. And I always say if your partner doesn't agree with you, that's your partner's opinion. Everybody comes from a different place of their upbringing, their morals, their comfort levels. And so that's one thing I think that's important, that they feel like the patient may disagree or may not be on board with what they want to do, but it's not like they're against it, it's how they feel.
They might just need more time and
They
more
do.
processing, because, a lot of times our feeling in that moment, or our opinion in that moment, obviously, is not fixed forever. It can change. And I
It can
mean,
change, it evolves. Yeah, you're
yeah.
right. One thing I actually do, Kate, here to help them with making an informed decision is I will offer them to speak with mental health therapists that we work with many of them in the area, many good ones in the great ones in the area, because I say to them, they will provide for you perspective of other patients and couples that they work with in the past. And when this patient or couple hears from another person they just met about other people's experiences, it does a couple things that are quite beneficial. Number one, it normalizes sometimes their ambivalence and their fear and their indecision about what they want to do. And number two, it really helps them understand that this is not the most straightforward decision when they have to go from their own eggs or own sperm to someone else's eggs to someone else's sperm. And so when you put it in that, and when you have them look at it in those terms, they also get that although it seems overwhelming, they are doing everything they can with another person to direct the next path.
Hmm.
They are the ones who are steering the ship, who are flying the plane to the next destination. It may take a little bit of while to get there, but I find that that third person, a third party who they don't know yet, who I refer them to, besides myself and my team, really is, I find, quite useful and therapeutic for their journey as they go through sometimes really difficult decisions of, changing over to donor eggs or even to adoption.
That's great. Well, and as you know, we also have our support groups are available. And as you know, we have specific ones focused on donor conception and adoption, and one that's very specific to that decision-making juncture, which I think is so important. So thank you so much for advising your patients on the kind of emotional and um, kind of, yeah, psychological part of the decision making, I think is really important.
Yeah. I mean, as you pointed out here, Kate, I always say that the emotional side is the hardest part of this process. I mean, it's not the medical side for the most part is fairly straightforward. It's been around for over 40 plus years. However, patients who come to see us, because many people are really type A and they're used to their task oriented, used to accomplishing what they accomplish, things that are concrete and tangible, they don't think about the intangible part of the emotional part of infertility. And when I look at the emotional part, there's really three things I see for emotions. It's going to be number one, loss is one of the emotions that people have because people who have infertility or they've had recurrent pregnancy loss, there's something that they want that they, can't have at this point in time, but they're trying to get to it. So in a sense, they feel lost, especially when they talk with their friends and colleagues, who have what they're looking for. So it's definitely a loss for many people the way they feel. They don't verbalize that, but really that's how they feel. The other part is anxiety. I mean, no matter who you are, if it's difficult to get something, you become more and more anxious. Also, there's certain things that you may feel that are out of your control you can't get to, and so the anxiety also increases. And many people have anxiety at baseline anyway. It's a very common thing we've seen since a couple years ago of the pandemic. I feel like there's definitely this uptick of baseline anxiety, no matter what your age is, what your profession is, what your, education is. And so that's one thing I think that is important to acknowledge. And the final thing is going to be loneliness. Think about this way, you have people who say don't are childless, they don't have any children yet, and see their friends who have one or two children, and it's difficult to really socially be with those people because they have kids and they don't have them. They may avoid things such as, holiday parties or other events because their children and they don't have children, so they feel lonely, they feel left out. And, I think the major part about these emotions, and I bring this up because I can tell when people are a little bit off. And I'll just say, okay, time out. Let's put all the medical stuff aside for a second. How are you doing? Tell me about what's going on. And a lot of times, the partner may bring up things before the patient does because the partner observes it, but didn't have maybe sense of courage to bring it up. But the forum that we have here, it's a safe space. They, bring it up and they essentially, you know, have a great discussion. And I say you have to think about you have to acknowledge your feelings, you have to navigate your feelings, and you have to normalize the feelings as well. And I think those are the three things that are important to really kind of think about the intangible side of this. And I think once you embrace that side, in addition to the medical side, which is a little bit more concrete, I think that patients really do, I feel like, get the most control and the most empowerment they can during this process as they go forward.
I love that you address that with all of your patients. That's such a relatable piece. I think no matter where your journey ends up taking you, everyone, has absolutely experienced the loss, the grief, the anxiety, the loneliness that goes into navigating this. So that's really wonderful that you make sure that your patients are taken care of, not just medically, but also, themselves as a person, psychologically, emotionally as well.
Yeah, and to your point here, Emily, I know that you guys have done prior podcasts. I remember saying it's okay not to be okay, right? And so that I love that title because I think many people feel guilty if they don't feel great or not in the best mood.
Mm-hmm.
Or, for instance, also too, pregnancy jealousy. People like, their sister or their friend is pregnant for them. And I say, listen, that's okay to be jealous. Like, no shame on that one. I'm not hating on you for that one. Like, that is something that is quite normal emotion. And it's always okay not to be okay. Because you have to acknowledge when you don't feel well. Because if you don't acknowledge it, you don't open up, things will become worse. And sometimes people just stop and there may be some tears, some little tears, a lot of tears. But interesting, once they stop crying, you can see this sense of relief and this sense of like more vision about, okay, I got that off my chest finally. Um, and now I can think about, okay, this has been holding me back. And now I can move forward with either more questions or other directions. So as you pointed out, Emily, it's a really important component, and it definitely is okay not to be okay. At that point in time. So definitely the most part is really, really important.
100%. So I know you've listened to the podcast already, so you probably know what's coming as we wrap up. But we do have two questions that we've been trying to
Yes.
ask all of our guests. You can answer them in whatever order, but
Yeah.
the first one is what's one thing that you would say to someone who has just started to grow their family? And
Mhm.
the flip side of that is what's one thing that you wish people would stop saying to people who are struggling?
Well, the first thing I go to what I would say, what things I hate or I don't like people to say to people is um, there's two words that should never be in the equation or the conversation. Number one, relax, and number two, what's wrong. Okay. So the relaxed part, although I get it, and I have a lot of older relatives, who would say that because it's a different generation. There's nothing about stress in fertility we've seen that has a correlation. And also, I think, just from just our societal kind of structures here with, seeing predominantly women who are anxious, I find that actually offensive to say to relax. This is really not accurate. Yes, we all want to relax, whether it be me thinking about balancing my checkbook or me paying for my child's education in the future. Those things I need to relax about, right? But thinking about fertility, it's not an issue of relaxing or tension. There can be different reasons for infertility, whether it be a biological reason, unexplained reason, or other things that come up. So that's the first thing. The other thing is what's wrong. When you say what's wrong, it implies that it's someone's fault that they're infertile. And last I checked, I never found somebody I walked in and said to them, it's your fault that you're not getting pregnant. I don't think any doctor would ever say that or ever think that, although I know a lot of patients may think that. But I think that's two things we really should, hopefully, people hear this podcast. Do not ever say, please relax or try to relax or never say what is wrong because those things put it back on the patient or couple as if there's something wrong with them. And that's the exact opposite of what you want to make them help them understand that it's all about them and what they bring and what they can do to help themselves. And so I think those are two things, Emily, that really drive me crazy. And I think people don't really, they're not malicious. They just say things in a way that could be worded differently. But we want to deflect blame. We want to deflect causality of the person and really turn it into what can be done and what can be optimized, as pointed out before, by them and also by their teams. That's what I would say for that. And the other part, what would I say to somebody who's starting the journey of family building? I would say have an open mind for this reason. Just like anything, if any of us can think about when you started college and how you envision the next 10 or 15 years after you finish college, I bet you two, or anybody listening to the podcast, it is not exactly not even close to what you thought it would be like, right? Right? Like not even close. Even myself, who had a pretty structured 20s and 30s where I knew I'd be doing medical school for 4 years, residency for 4 years, and industrial for 3 years, and then practicing afterwards. Things took a lot of twists and turns professionally and personally. But having an open mind helps you know that adjustments have to be made. You have to be open to pivoting. And knowing that, and one thing I always say, it's not how you start, it's how you finish. So your start may not be what you thought, but as long as you have the goal of how you want to finish and what you want for yourself, that's all that matters. And so definitely have an open mind. Know that it can be twists and turns. Know that the twists and turns sometimes makes you stronger and actually makes the journey better. Although it may not seem like that in the moment, but at the end of the day, only thing that really should be definite is the destination typically. Usually, however, there's a caveat to that. Sometimes the destination doesn't happen the way you want. It may not be two or three children, maybe one child. But I think that ultimately you still know that you want to be a parent, you want to build your family. And I think you have to be open-minded to the fact that there's nothing that's guaranteed in life. But the one guarantee that you can really put out there is that it will probably not go according to script. There'll be some variations, but at the end of the day, you have to make adjustments and be open to those twists and turns that may come your way. And I think when you do that, when you say that, if say something doesn't go the way a patient or couple anticipates, it's not as devastating or traumatic because okay, well we went left, we should have gone right. We can right this ship, we can go back where we wanted to in the future. And I think they just realize it's normal part of the course. And they know and they have faith that they're going to get to their destination. So that's what I would say if somebody were to, if I were to talk to someone and say, this is the one thing I would say to you as you start your journey.
I love that. Thank you. I know we're just about hitting our time, so you need to go actually take care of patients now. But thank you so much for sitting and chatting with us.
The other part too is knowing that infertility, it's medical, it's emotional, and it's also just, a great privilege to be a part of the journey and the story of patients that I've taken care of over the past 20 years. So thank you both for this opportunity to kind of share some pearls with prospective and current patients, share my experiences and also get to talk with you guys is always the best ever.
Oh, and thank you. We love talking with you too. Thank you for sharing your story, both professionally and personally. And we're so fortunate to have you be part of our community.
Thanks so much, guys. I'll see you soon.
We hope you'll join us next time for more family building stories and resources. Be sure to subscribe wherever you listen to podcasts to make sure you never miss an episode. And follow us on social media at AllPaths FB or visit our website, allpathsfb.org, for more information about our work. AllPaths Family Building is so grateful to the members of our circle of support who are vital to our ability to provide emotional support, education, and advocacy that is available to anyone who needs it. Today, we want to give a great thank you to our bronze sponsor, CCRM Boston. Thank you for joining us for this episode. Please help spread the word so that anyone who is struggling to grow their family can join the conversation. It's an honor to walk with you on your family building journey.